Thank you, Jacques, to invite me to talk about hip arthroscopy and preserving hip surgery. So, what about osteoarthritis of the hip? We know that there are two main factors, mechanical and non-mechanical. And we will see that with hip arthroscopy we can reach some of mechanical hip indication of osteoarthritis, mostly the femoroacetabular impingement. We can have some indication in post-traumatic hip hip trauma, and sometimes in inflammatory or in infection. My talk will focus on the femoroacetabular impingement, which is the main indication in hip arthroscopy. And in these lesions, the treatment will carry on early lesion with osteoarthritis tonus 0, of course, the best indication. You can go till tonus 1, or sometimes even till tonus 2 in patients lower than 40 years old. Philippon wrote a note about an article about the indication in hip arthroscopy when there is a joint space, and you can perform hip arthroscopy if the joint space is more than 2 millimeters. If it goes lower than 2 millimeters, then it's a predictive factor for total hip replacement. What about the concept of femoroacetabular impingement? I think now everybody knows about it. It's the abutment of the femoral head-neck junction on the acetabular rim. And how does it happen? Generally, it's people that perform sporting activities with high range of motion. But there are generally predisposing factors. Those predisposing factors are the alteration of the morphologic head-neck junction that we call CAM effect. And the second factor is the Pincer effect, which will be an acetabular overcoverage. We can have a mixed effect that will combine CAM and Pincer in 50 to 80% of the patient, and those factors are leading to osteoarthritis. Here is an example of the CAM effect, that you can see the bump on the head-neck junction. And sometimes there is no bump, but head-neck offset reduction. The neck is flat. This is always in the anterior-superior part of the head-neck junction. Here is a nice video to show exactly how the CAM effect will damage the cartilage on the acetabular rim. So here is the CAM, as you can see, on the head-neck junction. Here is the flexion of the hip, and in every flexion there will be an increased pressure at the acetabular rim. This increasing of pressure will move on the labrum and will make some chondral damage at the anterior superior rim of the acetabulum. So here is the kind of lesion we can see at the end of the trauma, repetitive trauma in hip flexion. What about the Pincer effect? It's generally it's secondary to an acetabular anterior overcoverage that could be retroversion, coxa profunda, or protrusio. And another video to show how the principle. You have the overcoverage of the acetabulum, and in deep flexion, it's the neck will abut on the labrum, the anterior superior labrum. So the first lesion will be on the labrum, not only on the cartilage, but on the labrum. Then it will extend on the anterior superior acetabular rim, and we can have contracule lesion that you will see. Contracule lesion is secondary to the decoaptation of the head that will make a lesion on the posterior inferior part of the acetabulum. And this will lead to posterior inferior osteoarthritis that we can see sometimes in patients in protrusio, for example. So what can we do to treat those femoroacetabular impingement? We can go by surgical dislocation, by minimal invasive surgery with anteroreter approach, and under arthroscopy. Nowadays, hip arthroscopy has become the leading technique to treat those patients. And we can see in a recent paper by Dom that there is better results at 2 years, faster recovery and better result at 2 years when it's performed under hip arthroscopy. So with hip arthroscopy, we will be able to treat the lesion. We can take off a labral lesion or reconstruct or suture, and we can treat some chondral lesions by microfracturing, taking off. But also very important is to treat the cause. We need to take off, to get rid of the cam lesion and to take off the pincer if there is a pincer. Here is the chondral management. If you have a chondral delamination, as you can see on those pictures, I don't know if I can do that. Yes. On those pictures, you can see that there is labral delamination on the acetabular rim, but the femoral head is still perfect. This is still a good indication if there is not too much lesion on the acetabular side. It's a good indication of microfracture if there is good indication of microfracture if the lesion is not too big. If the lesion is bigger, then you can do cartilage transfer like AMIC or ACT. This is microfracturing, doing small holes and then taking down the pressure of the fluid to see if the bone is bleeding. Okay. What about unstable chondral flaps? In these cases, you need to take down the chondral flap and then perform microfracture just like we've seen before. And sometimes you have a big and thick, unstable chondral flap, like in this example. It should go on. Oh, no video. In this thick chondral flap, you can take down some in between the bone and the chondral flap, and then do microfracture and sometimes even put some fibrin glue to try to repair these lesions. Once you have repaired all the lesions, the labrum and chondral lesions, you will need to perform about the cam management. So you need to find your landmarks. This will be on the pre-op planning. Sometimes if you don't really know where you are, you can use fluoroscopy during your surgery. And then you will do the cam trimming once you have found the good landmarks. So this trimming will be, for the superior parts, it will be in extension, but for the anterior superior part, you will need to be in flexion of the hip to be sure first you're not too deep inside the joint. It's important to take down the cam where it is, and generally it is in the cartilage. So you need to go in the cartilage, of course not go too far in the head. And this is why it's important to do some fluoroscopy during your first cases and to have the good landmarks in the preoperative planning. At the end, you will need to you will perform the final testing, I call it. I will put the hip in flexion, deep flexion, and internal rotation, and check that there is no more impingement on the acetabular rim. I will also do abduction and external rotation to look on still if there is no more impingement. So in conclusion, FAI is frequently a cause of osteoarthritis. In early cases, you can perform a good arthroscopy to take care of the lesion, but always search the cause, search for the FAI, search for the cam and for the pincer, and treat those predisposing factors. Second conclusion is that you only go if tonus 0 or 1 and if joint space narrowing is higher than 2 millimeters. Otherwise, it's too late and you will go for another surgery. Thank you very much for your attention, and I invite you to come to Lyon in June for the ISACOS Congress. Thank you very much.